one, thank you everyone for coming back and for being quiet with Michael's trick. Next up, I am going to introduce Dr. Tim Salomons. He's an associate professor of clinical psychology and director of pain, affect, and cognition lab at Queen's University. His work uses neuroimaging, quantitative sensory testing, and both quantitative and qualitative pain assessments to examine the cognitive and biological mechanisms that make pain salient and how individual differences in these mechanisms might underlie differences in coping and treatment response. So everyone please welcome Dr. Salomons.
Thank you, everybody. And yeah, thank you, Sarah. And Rajam probably is hiding outside, but you know, it's really great that she has done this all these years. And of course, we're all saddened that this is probably going to be the last one. But maybe we'll try to talk her into doing another. But yeah, no, it's a great place, to sort of mix science and clinical work. And it's great to be amongst people, all of whom care about pain. And so. I'm really glad. I was really happy when she invited me back. Okay, so what is pain? U.S. Justice Potter Stewart kind of threw up his hands and said, "I shall not today attempt to further define it, but I know it when I see it." Now, Justice Stewart was actually talking about pornography, but I think it applies equally well to pain. And so, we can ask, what does pain look like? So I'm going to show you using an individual who is receiving a 49-degree stimulus on their forearm.
Ow, wow.
Okay, so the first point is that we're rotten people, but a couple things come out of that, okay? So the first thing is that, you see, he's not just having a straight-up sensory experience, he's also having a quite pronounced emotional experience, okay? So he's not just saying, there's something on my forearm. He's, clearly having an aversion response, okay? And that is really, the combination of sensory and emotional things is reflected in the definition, which, you've heard hundreds of times in your life and probably 5 or 10 already at this conference. This is the old one, the 1979 version, so, an unpleasant sensory and emotional experience, okay? And so those two things are inherently part of the process. And I think, the sense of, the more I talk to sort of people in the public, the more I'm struck that people tend to think mostly of the sensory experience. And, I thought about, why is that? And I think it's because most people's lens is acute pain, okay? And so 99% of the pain that, regular everyday Joe without, who isn't living with chronic pain experiences is directly related to the thing that is causing it. Whether it be touching the hot stove or stepping on a piece of Lego, people really tend to see pain by default as a straight up reflection of whatever seems to be causing it, okay? We seem to have a little bit more discomfort and poorer understanding of the emotional part and how it relates to the sensory part. So to get started on kind of better understanding this relationship, let's ask another question. What is pain good for? Okay? Pain causes so much suffering that sometimes we wish we could do away with it entirely. But I'm going to show you that also isn't good. So this is an individual born without the ability to feel pain, due to a loss of function mutation in the sensory neuron sodium channel nav 1.7. So I'm just going to play a little clip of him. His description's a little gruesome, so I'll warn you in advance.
What?
Oh.
So I broke my foot. It was actually out in the woods, and it was nighttime, so it's pretty much like walking around with your eyes closed. Mm-hmm. And when I broke my foot, I didn't instantly know that I did it, because I was stepping over a stump, and when I stepped over, there was another log on the opposite side of it that my foot had got wedged into, and it twisted it, and I fell over and cracked it. And I didn't know that happened until after I tried to get back up. And when I got back up, I went to go put my foot down, and I could hear the cracking of bone, but then also I had like this, like a rush feeling, like a kind of like just like blood, like it felt like blood was going through my leg, kind of is what it felt like, but I wasn't actually bleeding.
Okay, so a couple things, stick out to me there. First of all, without the ability to feel pain, he's susceptible to things that you or I would routinely avoid. And when you talk to these people, you hear stories like this. Like right now as I'm standing at the podium, I will lean on one of my legs, and then sooner or later that's going to feel a little sore, and I'll just, without even thinking about it, shift onto the other leg. These individuals never have that experience, and so they're susceptible to things like joints wearing out because they're not being used. And certainly before people become verbal and aware of their situation, a lot of these people become have fatal injuries. So for example, a young infant, the parents may not even know that it isn't able to feel pain, and it will lean on a radiator while the parent isn't in the room. So it's actually a lot of these individuals die quite early on in life because they are unable to avoid dangerous situations. And so one of the interesting things that he told us, we were working with him and we were using a laser to stimulate his nerve. And at one point he said, maybe we better stop because this is starting to feel like when I used to burn myself with a lighter. And so I sort of infer from that as, when he figured out that he was like this, he would, maybe do a party trick for his friends and, try that out. And then he would look at his hand and realize, oh, that's a bad idea. And so he would learn what it felt like maybe when he was going to get injured without necessarily feeling pain. So he was about 35 when we interviewed him, and he's taken that lifetime to basically learn things that you or I could, avoid without learning. Ow, ow, oh. So what this suggests is that pain functions as an unlearned alarm to warn us of potential danger to our bodies. And if we view it this way, it makes a lot of sense that pain is both a sensory and emotional experience, okay? Because the sensation tells us what part of our body is in danger, okay? And it tells us things like, what kind of stimulus it is. We have pretty rich information coming in to tell us about the stimulus. And then the emotional component, it warns us of danger and it primes us for action. So, the two really work together in that way. And, this alarm metaphor is quite well used, and I think the reason it's well used is that it really nicely describes, like an alarm, an alarm can be insensitive. So, we think of a fire alarm without batteries. The individual you just heard from, it's like a fire alarm without batteries. The alarm, it just is not sensitive to anything that's happening. Now, unfortunately, for a lot of our patients, we get exactly the opposite, that they have a fire alarm that's going off all of the time. And what we are often doing, and certainly as psychologists, I'm a clinical psychologist, as Sarah was mentioning, and as psychologists, a lot of what we're doing is trying to teach people to tune that alarm, trying to, tune their emotional responses so that they're appropriate to the danger. And, part of what that does is reduces suffering, as, the very fascinating talk we just heard. Now, we as psychologists really have a great role to play in this, and so we've designed a lot of treatments such as CBT and ACT to help people tune, manage that emotional component, okay? Now, I could stand up here and tell you about, psychology's greatest hits and, all of the great things we've done. Instead, I'm going to go the other direction and tell you a bit about psychology's biggest misses. And Historically, the role of psychology has been offering explanations when the cause of pain was not readily apparent, okay? Unfortunately, even to this day, medical science has not had a lot of luck in explaining a lot of chronic pain. And this has created an explanatory vacuum in a lot of cases, into which, unfortunately, a lot of unfalsifiable psychological explanations have been drawn. One of these was the notion of psychogenic pain. And this 1959 article by George Engel was one of the really influential articles, and it attempted to explain how pain can occur in the absence of clear pathology. Now, the sort of basic idea behind these kinds of explanations is that pain exists to fill a psychological need. Engel talked a lot about pain resolving guilt. But this kind of explanation continues, unfortunately, to be prevalent and takes a lot of forms. I was reminded of it in Joletta's talk the other day when she talked about individuals with fibromyalgia being explained as women seeking attention. That's another very unfortunate and damaging example of this idea that pain is somehow filling some psychological need. And I won't bore you by going through each, iteration of the DSM for, their different pain explanation or their different diagnoses over the years. But up until very recently, most of these diagnoses in the DSM contained this kind of causal language, and they had explanations for how psychology created pain. And a lot of them also had this idea that if pain is medically unexplained, then it must be this kind of psychological diagnosis. And, that really is unfortunate, because then also when people now come to us, they believe that that this kind of diagnosis is being given to them. Now, in DSM-5, which, is much more recent, we've finally gotten rid of the last traces of that kind of causal language. And at least on the surface, there's no implication that pain that is medically unexplained must be psychological in origin. The only pain-related diagnosis now is something called somatic symptom disorder. And I think for the most part, they've kind of got it right. And where I think we've got it right is that we're no longer trying to explain pain using these kind of unfalsifiable, this kind of unfalsifiable psychobabble. Now we're focusing on the distress that pain causes and trying to manage thoughts and feelings and behaviors that are associated with pain. And I think that's appropriate. Pain is a stressor, okay? And that's what I try to remind people when I see them the first time is, you're not here because I think you're crazy. You're not here because, I think that your pain has some, you're trying to resolve guilt or anything like this. You're here because your pain is stressful. And, just the same as we would work with somebody who's going through a divorce or, a bankruptcy or anything like that, we can assist people when they're feeling pain. But even though I think we're on the right track here, I'm going to argue that we're still leaving ourselves open to bad practice based on problematic ideas about the relationship between sensory and emotional aspects of pain. And I'm going to illustrate this using a case study that accompanied the DSM-5. So it's the DSM-5 case study book. And in this case, we see case 9.1, pain and depression. We meet Michelle Adams, who's a 51-year-old former hairdresser. And the reason for her referral is debilitating chronic pain for the past 13 months. And her primary care physician has requested a psychiatric evaluation. Okay? So I'm just going to walk through some of the criteria. We see down at the bottom that one of the criterion is that the pain is typically longer than 6 months. And that's met. She's been suffering from unbearable back pain for the last 13 months. And then we can look at some of the thoughts and the distress that is being caused. So she's been unable to return to work since her accident on account of pain. She often found herself up at 5 a.m. and pain woke her several times before she finally got out of bed in the afternoon. She had stopped bathing daily and gotten slack about cleaning her apartment. She just didn't feel up to socializing on account of the pain. So clearly this pain has had a tremendous impact, and I'm sure most of you have met patients, very much like this one. Okay, so one of the important criteria is persistent thoughts about the seriousness of one's symptoms, okay? So, it really is about how you're thinking about pain. And the patient expresses this. She says, "I'm so depressed, it's ridiculous." And it's reported that she often felt hopeless of any possibility of living without pain. Now, where we get into, where it gets a little bit more problematic in my view is that this diagnosis hinges on whether we consider her cognitive and emotional response to be excessive or disproportionate. Now, we reviewed in the previous slide that she's been experiencing extreme pain for 13 months. She's confined to a wheelchair, she's unable to work, she's lost her social life, she's not sleeping well, and her primary care doctor doesn't know what to do with her. Now, I would ask you, is it really excessive or disproportionate that she feels depressed and is losing hope about the possibility of living with pain? If someone's life has been torn apart in this way, why is depression or hopelessness a disproportionate response? And I strongly suspect that in cases like this, excessive isn't judged by whether the patient's emotions and thoughts are disproportionate, but rather by how much distress people around her, including her clinician, can endure. And I'm going to also suggest that our evaluation of what's excessive is tied to a still prevalent view that pain is a simple reflection of injury or noxious stimulation, and that in the absence, when we can't find that injury or noxious stimulation, we often go into this mode where we blame the patient for being overly emotional. So let's look at some other details that are reported in this case to kind of prove this. So here we hear, the psychiatrist was struck by both her appearance and her manner. Here was a woman with shaggy silver hair and dark sunglasses, seated in a wheelchair, who offered a limp handshake and a plaintive sigh. She asked the psychiatrist if he would mind pushing her wheelchair into his office. She was tired from a long commute. Nobody on the street, she reports, nobody on the street offered to help me. Can you believe that? She described a hot temper as a family trait. She revealed several arrests for theft in her 20s. Now, let's say we found an additional piece of information. Let's say we found out that this patient had a tumor on her spine and that the doctor gave her a choice. Either we, operate and you risk paralysis, or you have to live with the pain. And she decided that she was going to live with the pain. Okay? I wonder if then we would be talking about her hot temper. I wonder if we would then be making notes about her shaggy hair and sunglasses, or whether it would suddenly be important that she had arrests for theft in her 20s. So what I'm trying to get across is that all of these details seem to be trying to paint a picture of this patient as kind of this histrionic weirdo that and somehow that she's to blame for her own situation. And I can't help but feel that if we had a clear medical explanation for the pain, we wouldn't even be reporting these kinds of details, okay? And I think that that's really important, because I think what it says is that even though we have sort of expunged these, the causal language from the diagnosis, and even though we're no longer, making the diagnosis dependent on whether the person has a medical explanation, this type of thinking is all too prevalent, okay, and it continues. And I would say in this instance, it isn't all that inaccurate that the patient says, these doctors don't believe me, they think I'm lying, okay? And this is the case made nicely. So in the absence of medical explanations, we often rely on schema, and we blame the patient. And this case is made really nicely in this great article. It's a 2009 article that I often assign in my pain course by Tate and Chibnall and Kalakalani. And yeah, basically they say when there is symptom uncertainty, when we don't know what is causing the pain, we tend to rely on these kind of schema. We take shortcuts, and and often these shortcuts are biased. Okay, and one of the biases that they report on is having to do with women, or not women, but having to do with individuals who come in expressing strong emotions. So in the absence of clear pathology, patients appearing histrionic receive fewer tests and less follow-up. They're more likely to be denied appropriate treatment, and they're more likely to have pain attributed to psychological causes. And I left the word histrionic in here on purpose because I just want to comment on the kind of clear sexism that goes into these kinds of things, because women tend to, a lot of reports in the clinic suggest that women are expressing more emotion around their pain. And because of that, it's often thought that, as a default, clinicians using these kinds of schemas will often downgrade, they mentally downgrade pain. They say, okay, that 9 is probably a 7. They're probably, overestimating their pain, and women tend to get undertreated on that basis. We've done a little bit of research, which I'm not going to talk about now, but it suggests that actually it's probably not women who are underreporting pain commonly. It's men that, or it's not women who are overreporting, but rather men that are inaccurate in sort of underreporting, particularly if they're reporting to a female. Okay, so just to review what I've been talking about up to this point, our definition of pain has important implications in our clinical encounters. How we think about this relationship between sensory and emotional aspects of pain really makes a difference in clinical encounters, okay? So a few things that we have to sort of look at and make sure are part of our understanding of what pain is. Pain's emotional component is definitional, and it's central to its function, okay? It's not an unfortunate byproduct, it's central. And again, this is reified in the ISP's definition of pain, that pain is both emotional and sensory. Another thing is that how we conceptualize the relationship between sensory and emotional components of pain can become a critical piece of the clinical and social context in which individuals live with pain, okay? So if people are expressing this kind of emotion and clinicians are uncomfortable with it, that is a social dynamic that affects pain and affects suffering, okay? And for that reason, there's been calls that we need to think about pain in more of a social context. So many of you may be familiar with this proposed definition of pain that Williams and Craig put out in 2016. Pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. So Williams and Craig are not just calling pain a sensory and emotional experience, but also a cognitive and a social one, okay? And what this really brings home is that as adult humans, pain occurs in a complex context. If we sprain our ankle, we're not just thinking about the pain we're feeling in our ankle, we're also thinking about what this might mean for our lives. Will I be able to, go for a walk with my wife? Will I be able to, run in the backyard with my kids? Will I be able to go to work? What's going to happen? Okay, so this is all part of the context in which pain occurs. So this is a definition that really highlights the complexity of pain as a human experience, and it prompted a rethink of the original definition. The other thing another clinical conclusion we can draw is that by definition, the reality of pain does not depend on observable somatic pathology. And I think that that's another, many people consider in this definition the most important part to be the sensory and emotional experience. But I actually think this last phrase is perhaps most important, because what it suggests is that it's, you don't have to see, my leg doesn't have to be injured. If I say my leg feels like it's on fire, you don't look at me and say, no, your leg's not on fire, right? So you say, okay, he's feeling pain that has a burning quality, okay? So even in this definition, they go out of their way to say that, it's not dependent on seeing that pathology, okay? Now, there was, the reason I have 1979 after this definition is that there has been an update, and people were not really comfortable with this last phrase, even though I think generally people are happy with the fact that it allows for pain in the absence of apparent pathology. But the complaint was, that it calls into question the pain of organisms that are unable to describe their pain. So for humans, we're thinking about, very young people, people with disabilities, people with language barriers. These are very important things in terms of care. And also, it doesn't cover animals. I mean, a rat or a dog can't describe to me the pain that they're feeling, but we would certainly not say that because of that, they don't experience pain. So the IASP task force really set out to kind of change this definition. And they deliberated for 2 years and changed only a couple of words, but perhaps in important ways. An unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it's no longer dependent on the ability of the organism to describe it. And so this allows for, pain that's experienced by, the very young or by non-human animals. Okay, now that gets a little tricky, okay? In the section that follows, I'm going to talk about some public policy examples of how we judge pain in nonverbal beings. And as you're going to see, observable behaviors are only one of the key pieces of evidence we use, but certainly not the only one. So I teach an honors seminar in pain, and one of the great ways to get students to think about what pain is to talk to them about a long-standing scientific debate on whether fish feel pain. Okay, and this is a really kind of interesting and, it's a very interesting debate that has a lot of implications for how we treat fish and other animals as well. So one of the ways we determine whether a fish feels pain is to see if its behavioral responses to nociception resemble those of other organisms who are able to describe the pain. So here, Braithwaite and Bulcott say, the fact that changes in the normal behavioral repertoire of a fish studied occurred after the administration of a noxious event does allow us to infer that the fish attended to this noxious stimuli in a way that was not just merely responsive. Okay, so the first pillar of evidence that they're using to argue that fish feel pain is that they behave like they're in pain. They swim away from noxious stimulation. But behavior alone isn't enough, because even fruit flies show aversion responses, and few of us would say that a fruit fly feels pain. So in evaluating whether nonverbal organism feels pain, we also rely on a second pillar of evidence, and that's whether the organism has the necessary biological mechanisms to experience pain. And so often, often then they will call on whether, an animal has nociceptors and whether it has the sort of brain apparatus to feel pain. And so here Braithwaite and Bulcott say, teleosts possess specialized cutaneous pain receptors that are sensitive to damaging stimuli, such as excessive heat and noxious chemicals, and to mechanical pressure. The presence of a nociceptive system is clearly a necessary component for the perception of pain, but alone it does not provide evidence that fish have an awareness of stimuli we would consider to be painful. Okay, so they're saying it doesn't necessarily prove it, but they have the machinery in place to feel pain. So it is quite plausible based on their behavioral responses and their biology that fish feel pain. Now, generally when people are trying to infer pain in animals or nonverbal humans, they will use these same pillars of evidence. They will say, does it behave like it's in pain, and do we think it has the necessary biological apparatus? But just because we agree on the types of evidence that are important doesn't mean that we necessarily agree on how that evidence should be interpreted. So Brian Key is another player in this argument, and he looks at the same evidence and doesn't believe that fish are able to feel pain. So he says, the alternative view that fish instead respond to noxious stimuli reflexively and with a limited behavioral repertoire is defended within the context of our current understanding of the neuroanatomy and neurophysiology of mental states. And he says, while mammals and birds possess the prerequisite neural architecture for phenomenal consciousness, it's concluded that fish lack these essential characteristics and hence do not feel pain. So he's kind of claiming a higher bar for what the necessary biological mechanisms are. Okay, so what makes the difference here? How can two sets of scientists observe the same evidence and reach opposite conclusions? I'm going to examine that question using a similar debate over a different type of organism. Well, the fish debate occurred in the pages of scientific journals that frankly most people are never going to read. This debate took place in a very public forum. And that was the recent Supreme Court case on abortion, where the case was Dobbs versus Jackson Women's Health Organization. The US Supreme Court case that dealt with the constitutionality of a 2018 Mississippi state law that banned abortion operations after the first 15 weeks of pregnancy. And this was the case that resulted in Roe versus Wade being overturned and really has made a huge difference to abortion policy in this country. Now, what made that case, I mean, the case is relevant, I think, to all of us, but what it made it specifically relevant in this setting is that some new evidence in the case that was presented was the possibility that a fetus might feel pain prior to viability at 24 weeks. And again, you're going to see the same pillars of evidence used that were used in the, in the fish debate. We're going to look at observed responses, and we're going to ask whether fetuses have the necessary biology. Okay, so this is a amicus brief that was prepared for the state of Mississippi's case, so the quote-unquote pro-life side of the argument. And this was prepared by Maureen Kondich, who is a neuroscientist at the University of Utah. And so here are some of the arguments that she used to suggest that fetuses can feel pain prior to 24 weeks. She said, 4D ultrasonography confirms that even before viability, fetuses react to painful surgical procedures by grimacing and making other facial gestures recognized by science as a universal language of conscious pain experience. I don't know that I would agree with that science recognizes that so universally, but again, we see the same thing as we saw with the fish. These fetus is behaving as if it is in pain. And then she also addresses the other part of the argument, whether a fetus has the necessary neurobiology. Okay, so she says, now, in terms of addressing whether a 15-week-old fetus can feel pain, the question that needs to be asked is whether the cortex is necessary for pain, because prior to about 20, we argue about what is meant by a fully developed cortex, but prior to about 22, 23 weeks, there's really not much of a cortex at all, nothing. And to make the case that the cortex isn't necessary, Kondich cites a paper, so Stuart Derbyshire, who some of you know is a very prominent pain neuroimager. And about 15 years ago, he asserted that it was impossible for a fetus to experience pain prior to cortical development. And as Kondich points out, he's kind of changed his tune in recent years. So Kondich says, faced with mounting evidence to the contrary, Derbyshire abandoned his position on the cortex's necessity just last year. Okay, so Derbyshire is now arguing that a fully intact or a cortex is not necessary for the experience of pain. And so let's have a look at the the paper that is cited in that. So this is a paper by Derbyshire and John Bachman called "Reconsidering Fetal Pain." And here's the sort of relevant piece of this in terms of the necessity of the cortex. Several papers have now been published suggesting that the necessity of the cortex for pain experience may have been overstated. Now, I can tell that the suspense is killing you, so I'll let you know the papers he's referring to are ones that I was involved in. So let's have a look at those papers. So he says, One study has, for example, demonstrated continued pain experience in a patient with extensive damage to cortical regions generally believed to be necessary for pain experience. Now, before I go into that, I'm just going to give a little bit of background. Prior to us beginning to use neuroimaging, most of what we knew about the necessary equipment for pain came from animal studies, and neuroimaging was really useful because it allowed us to look at humans in vivo while they were experiencing pain and sort of figure out what brain regions were being activated during that experience. And already by the time of this review in 2005, we had a fairly substantial number of studies that were adding up and telling us, what these regions were. So you see there the anterior cingulate, the insula, the thalamus, primary and secondary somatosensory cortices, a number of regions like this. And this is pretty much ubiquitous in pain studies. So here's just a later review. This is a tool called Neurosynth, and this is 311 pain studies kind of meta-analyzed. And I'll tell you, as somebody who's done pain neuroimaging, if you do a study of pain in the scanner and you don't get a kind of map that looks something like this, you've probably done something wrong. We see all these same regions, pretty much any study you run with pain in it. You see the anterior cingulate up there, you see the thalamus, you see the insula, so it is, the evidence is pretty strongly convergent that these regions are activated when people are in pain. Okay. Now, because these patterns of activation were so ubiquitous, there were a lot of calls for, maybe we can use these kinds of maps as, medical or legal evidence that people are in pain. And I want to show you I'm going to show you a couple of studies that kind of challenge that assertion, and they are the studies that, in fact, Derbyshire and by connection Conditch were using. Okay, so this is a study that I published with my colleagues Justin Feinstein, Saib Khalsa, and David Rudraff back in 2016, called Preserved Emotional Awareness of Pain in a Patient with Extensive Bilateral Damage to Insula, Anterior Cingulate, and Amygdala. And you've actually already met this patient. This was the patient we saw right at the beginning who clearly had very robust pain responses. He, not only the sensory component, but clearly he had a strong emotional component. And now I'm going to show you an image of his brain. Okay, so this is not just a sort of darked out, lousy picture. All the regions in black are actually lesioned. About 30 years prior to our meeting the patient, they had experienced post-herpetic encephalitis that quite intriguingly targets the what we would call the limbic system almost exclusively. So this patient has almost no anterior cingulate. The insula is almost completely lesioned. Is damage to the amygdala, ventral medial prefrontal cortex. There's widespread damage all through the brain. Okay, and it is important to note that we did see this patient about 30 years after their injury, because one of the things we can't rule out is that because pain is such an important function, that it's sort of multi-determined in the brain, and that functionality was regained over those 30 years as sort of an adaptive response. Okay, it would have been really nice had we seen him right after his injury and determined whether he was still able to feel pain. You'll also note that while some of these quote-unquote pain matrix regions have been lesioned, there still is a fair bit of intact cortex. And what that means is that this patient, I don't think Derbyshire was that far off to say, it just calls things into question. But certainly this is not conclusive evidence that the cortex is not necessary for pain. It just speaks about some of the particular regions. So then the other study that he calls on, a further study has demonstrated activation of areas generally thought to generate pain in subjects congenitally insensitive to pain but receiving noxious stimuli. And this was a paper we published in 2016 in JAMA Neurology. And you've already, again, met one of these patients. So basically, we had 2 patients with congenital insensitivity to pain, and we put them in the scanner. We gave them a stimulus, a stimulus that healthy controls found painful, and we compared their responses to the healthy controls. And here's what we find. The red regions are just a neurosynth-generated pain matrix, okay? And on the top, you see the control patients. In the blue regions are regions that were activated when we poked them with the mechanical stimulus. And then down at the bottom, or in the third row, you see the similar responses of the congenitally insensitive patients. And in the second row, you see the individual responses. And you can see that in the thalamus, in the insula, S2, ACC, and then across the entire pain matrix, the levels of activation are pretty much identical in the 2 groups, okay? And what this says is that just because we see this pattern of activation, it doesn't mean that we're observing somebody in pain, because obviously the congenitally insensitive individuals are unable to feel pain, okay? And so what this says to us is that, so the first patient says these pain matrix regions are not necessary for pain, and what this suggests is that seeing these patterns of activation is not sufficient evidence that an individual is in pain. And so we were contacted by the other side of the debate. They said, okay, they're claiming this. Is this really what your papers are saying? And so we were part of a large group of pain scientists who signed on to this sort of opposing amicus brief. And I'm just going to walk you through some of the arguments that were presented there. So Dr. Condich's amicus brief relies heavily on the article Reconsidering Fetal Pain by Stuart Derbyshire and John Bachman, which attempts to call into question the necessity of the cortex for the apprehension of pain. 3 authors of the 2 most important studies used by Derbyshire, Dr. Salomons, Professor Iannetti, and Dr. Feinstein, signatories to this amicus brief, assert that the results of their studies are being misinterpreted by the Derbyshire article and consequently by the state's amici. So citing a study co-authored by Dr. Salomons and Professor Iannetti on patients congenitally insensitive to pain, Derbyshire suggests that the results support their claim that the cortex is unnecessary to perceive pain. The study actually shows that in the absence of activity in functioning nociceptive sensory fibers, activity of the thalamus and cortex is not sufficient to generate pain. The study does not show that the cortex is unnecessary for pain to be experienced. So one thing this debate taught me is that, we as scientists try to deal in very guarded conclusions, okay? We talk, we try to qualify our work so that it's not over or underinterpreted. And to be perfectly honest, I don't think that what Derbyshire said was really that unreasonable. He is saying this kind of calls into question the role of the cortex in pain. That's a much safer conclusion, and I think a reasonable one, than the way that was used by the court. In the court, it was used to say the cortex is unnecessary for pain. And we even dealt with the opposite when we were putting together this MSA. They originally wrote in that our papers conclusively showed that the cortex is necessary, and we had to say, whoa, hold it there. Like that, we're not saying that. Our papers did not make any strong claims whatsoever about the necessity of the entire cortex. They just spoke about a few of the regions that have commonly been involved in, or commonly been called the pain matrix. Now, what this underscores is that if it's available, as all of you know, self-report is still, and I believe always will be, the gold standard for judging whether an individual is in pain. It does, however, leave us with substantial ambiguity when evaluating whether a non-verbal organism is experiencing pain, because if we go in and say, if we're trying to make a claim that an organism has the necessary biological machinery to feel pain, and we don't know what that necessary machinery is, it's going to be very difficult, okay? And I believe a substantial source of this ambiguity is due to differing conceptualizations of what pain actually is. Okay, so Derbyshire also misinterprets, this is another piece from the amicus brief. Derbyshire also misinterprets the result of a one-patient study conducted by Drs. Feinstein and Salomons. Derbyshire claims that the patient's experience of pain with a partly functioning cortex somehow provides support for the idea that a cortex is not necessary to experience pain. The study actually concludes that the patient's experience of pain was due to the damaged brain's adaptability to develop circuits around the damaged section of the cortex. The study emphasized that many other regions of the patient's cortex were intact and could potentially be mediating the pain experience. Okay. Again, we have this substantial ambiguity about what the necessary regions are. Okay, and that's where I think the opposing or maybe differing definitions of pain become important, okay? So again, we're examining why two sets of scientists can look at the same evidence and draw different conclusions. And I think we can trace it to different conceptualizations of pain. So here's the definition of pain that Kondich is using. In the simplest sense, pain is an aversive response to a noxious, i.e. physically harmful or destructive stimulus, okay? Now, using this definition, we could reasonably conclude that a fetus could feel pain. But using this definition, we could also reasonably conclude that a fruit fly can feel pain, okay? Because we're saying pain is just an aversion response to a noxious stimulus, okay? And I'm going to further, just in terms of demonstrating the differing conceptualizations of pain, I'm going to draw your attention to another quote here. Studies show that decorticate or hydroencephalic patients are capable of conscious behaviors, including having adverse reactions to pain. Okay, so first of all, they're kind of taking for granted that a cortex isn't necessary for consciousness, but I'd also point out maybe a sort of slight, subtle but important thing. She's saying adverse reactions to pain. Okay, so the pain is it's like pain is something you're responding to. It really is conflating pain with the thing that is causing it. You're responding to pain, okay? And in a very, in this kind of very simple, reflexive conceptualization of pain, pain and nociception are very much conflated. It's yesterday we saw that age-old diagram from Descartes of the boy putting his foot in the fire. And that shows a kind of specificity view of pain, where pain is just a simple reflection of the boy puts his foot in the fire, labeled line brings the signal up to the brain, and voila, pain. And this is that kind of thing. Basically, pain in this kind of conceptualization, pain and nociception are basically seen as the same thing, okay? And as raised in the counter brief, Dr. Kondich has conflated those things. The process of nociception is only part of what's required for pain to be experienced. That is from the ISP definition. Okay, so I say this to highlight the differing conceptualization. So on the one hand, we have pain as a simple nociceptive reflex. And then on the right side, we have pain as a complex biopsychosocial experience, okay? So the definition Kondich is using is much further to the left. It's much more of a nociceptive reflex. And thus, it makes sense why she draws the conclusions she draws. The ISP definition of pain is much closer to the middle. It's much more allowing for complex biopsychosocial experiences. And then the proposed Williams and Craig definition is much further over to the right. It takes all of these components into consideration. So I'm not going to come out really strongly and say where we should draw the line along this continuum, okay? This is where we decide, what we decide pain is an ongoing debate. Okay, and it's, I'm not going to make strong statements about whether a fish or a, whatever type of organism can feel pain, because it really depends on how we, where we draw our definition along this continuum, okay? And in some sense, I don't know that within the context of the abortion debate it really matters, because truthfully, I don't actually think that pain is relevant to the abortion debate. I don't think it moves the core debate one way or the other, because somebody who is pro-choice, if somebody is going to allow the mother to make a decision about terminating a fetus, they would also allow the mother to make a choice about pain incidental to that thing. The same as a mother is able to sign consent for her child to go through a painful dental procedure. On the other hand, somebody who is quote-unquote pro-life, I don't think that they would be satisfied if we said, well, okay, we're still going to terminate the pregnancy, but we're going to anesthetize the fetus before we do it. I don't think that that would change their view about whether an abortion should happen or not. So really, I think it leaves you kind of asking, why are they bringing pain into this debate at all? And I think that the reason has most to do with one of pain's essential, one of the essential reasons why we have pain, and that is empathy, as we talked about empathy yesterday morning. If we believe that a fetus feels pain, we would do what we would do for any organism who we believe is in pain, okay? We would offer them the support that we would want in that situation, okay? And so I can't help but feel that pain has been brought into this debate not to change the debate one way or the other, but rather to draw empathy for that fetus and to evoke a protective instinct. And I think that this is going to be especially important now that Roe versus Wade has been overturned, because I think what you're going to see is that it's no longer, abortion decisions are no longer made by courts. They will be made at the ballot box, okay? Because individual states will be able to determine what their own law will be. So they will then be appealing to voters. And that's where this empathetic response becomes very important. And so we felt it was really important that we address that and clarify for the public the issues around this. And so we wrote this editorial in Nature Neuroscience last year, sort of outlining our view of it. And I'm just going to read a couple of sections because I think they summarize the arguments very well, and sort of how we think about how our definition of pain is relevant in public policy debates. So, the state of Mississippi's case presents clear evidence that fetuses are capable of nociception. And this would be sufficient evidence if we were to use a definition cited by the state at the district court level. Pain is an aversive response to a noxious, physically harmful, or destructive stimulus. Such responses would not be sufficient, however, using the IASP's definition. In addition to specifying that pain and nociception are different phenomena, the IASP acknowledges the complexity of human pain by stating that pain is learned through life experience and is influenced by biological, psychological, and social factors. In humans with full cortical maturity, pain is not a simple sensory signal or motor imperative. It's also a complex emotion influenced not only by the unpleasantness of the perceptual experience, but also by its meaning for us and those around us, okay? And as we've heard very much at this conference, the suffering we experience as adult humans has a lot to do with the meaning for us. It has a lot to do with how we think about how it's going to affect our families, ourselves, our self-image. So it's a very complex type of suffering that we experience. Those who would compel a woman to carry a fetus to term so it won't feel pain must be clear about what they mean when they talk about pain. They can't ascribe pain to a fetus using criteria that would equally apply to a fish or fruit fly, but then ask the public to project their own experience of pain on that same fetus. Fully developed humans have a cortex to process nociceptive input and to associate that input with adaptively relevant sensory, cognitive, emotional, and social information, okay? And we further argue, for this reason, abortion policy has profound moral and ethical consequences. For this reason, it has to be grounded in the most accurate scientific arguments. It's also inevitably influenced by emotional arguments. Both are important, but they should not be conflated. Evidence suggests the claim Evidence supports the claim that a pre-viable fetus is capable of nociception. Any suggestion that it feels the same pain that a cortically mature human feels, however, is an emotional appeal that runs counter to what we know about the brain and how it generates complex subjective experiences. Okay, so we can call a fetus's experience pain, but we shouldn't confuse that pain with what you or I feel as fully grown individuals with a fully developed cortex. And with that, I'm going to thank you for your attention and take questions.
All right, thank you very much for that. Any questions? I think you flabbergasted them.
I scared everyone off.
Anything online? All right, oh, we got some over there.
Thank you so much, Tim. A really great presentation, and actually I didn't know any of that history of your involvement, and really, really fascinating, and I think you unpacked that so well, and I know it's such a sensitive issue, so I think you did a good job of that. I can't resist asking, though, your opinion on the new definition of pain. For you, is this an improvement or not?
I don't think it is. I think it's about the same. I actually thought described was fine, and it was clarified by Aditi, who's a very prominent Canadian philosopher of pain. He said, don't think of it as described. You can think of it instead as describable. So it doesn't matter that you actually described it. It's that you could describe it. And really what he's linking it to is the phenomenology of pain. Now, the question that inevitably gets asked then is, would you rather Williams and Craig's definition that takes the cognitive and social components in? And I have to say, even though, I believe very strongly in, the social component of pain and the relevance of that, but I'm not sure that I would necessarily call it definitional, because I think what we could say about pain having a social component, we could say about almost any experience we have having a social, everything we do is socially embedded. And so I don't know that that necessarily helps us distinguish pain from other experiences. And that really is what a definition is for, is to distinguish pain. What makes this different from sadness, for example, and I don't think the, claiming that it's influenced by social factors is necessarily definitional. So yeah. I'm pretty happy to keep the ISP definition as it kind of is, I suppose.
Yeah, I'm right there with you. I wrote a letter to pain that I think nobody read, or nobody cared about, making that point that you just made about the Williams and Craig. And I think for me, what's a real loss from the 1979 definition, and I should add a caveat here that the updates to the notes were good and hugely needed. It was embarrassing what was in those notes up until a couple of years ago. But then what I like about the 1979 language is first of all, we use the word "or," which protects us from assuming anything but non-human animals, but it also just places pain in the words of the person living with pain, and it empowers those words. And what I don't like about the word resembling is like resembling according to who. Right. And I think there's this shift in power there that's happened that we haven't really unpacked in how how that plays out for some of these applications of the definition.
Yeah, absolutely. And I think, if you're somebody who has sort of looked at these various definitions, another one that came up around the same time that I often talk about is the Cohen and Quintner and Van Rieswijk one. And I think the one there that really troubled me was they insisted that pain should be mutually recognizable, which is a way of acknowledging a social element of pain, but I don't like it because what if it's not, what if I have pain and no one else is able to recognize it? Does that somehow make it that I don't have pain? I don't believe so. I think it would be great if pain were mutually recognizable. It would be great if pain was always recognized by people observing, but as anyone who's talked with people in pain will know, one of the most frequent things they hear is, "You don't look like you're in pain," which is like, oh, So, you know, I am certainly, you know, in favor of, I'm certainly cognizant and of the fact that it is occurring in a social context and that it, you know, needs to be described. But I stop a little short of wanting to reify that it somehow, or imply in any way that it doesn't exist if it, you know, we don't recognize it as resembling, or if, you know, it's not mutually recognizable, quote unquote.
Thank you very much. I thought that was really interesting, and I really loved how you brought it, you know, to that very contemporary argument.
Thank you.
I suppose, so if we can call, and this is my view, suppression of abortion rights or access to sort of safe and legal abortion, if we can call the suppression of that fascism, like I noted that you kind of had the definitions of pain, and then you also separated it out into, well, then there's this emotional argument.
Yeah.
Yeah, and I guess I'm just wondering if you're being a bit generous with that.
Yeah.
Do you have any comments on that?
Yeah, well, I would guess that my views on abortion are probably not that far from your own. But mostly, I'll put it this way. When I read Kondich's, so, you know, the way the legal system works is that these things don't just go straight to the Supreme Court. They work their way up different levels of courts. And I will say that the argument Kondich put forward at district court level was shocking. And just, I mean, I would say shocking to the point of being disingenuous. You know, I was like, you can't actually, like, you can't believe that this summary of the scientific evidence is correct. The part of the reason that maybe I'm a little cautious is I don't think that, you know, if I can say we on the left, if I on the left am you know, immune from those kinds of biases. And certainly I saw when, you know, when our side of the argument was trying to put words in our mouth. You know, I don't think one side is necessarily, you know, I don't think either side necessarily has a sort of stranglehold on objective truth. You know, and this is where I think we have to recognize, like, because you know, one thing that struck me personally is my different emotional reaction to, you know, initially when I was teaching fish, you know, the fish debate to my class, and, you know, I was sort of glad this new one came along because it was much more relevant and much more interesting to people. But, you know, when I was teaching that one, then I fell, you know, where I fell on it was, well, if we don't know better, we should act on the side of being, you know, of protecting the fish. And I noticed, you know, when they contacted me about this, my emotional reaction was quite different. I had a different kind of leaning. And so you have to then acknowledge that, okay, I'm not, as much as I'd like to think that I'm being purely objective, I come into this with an emotional, you know, fish to fry, so to speak. So.
That was amazing. Okay, we're scooching in to break a little bit. Tasha had her hand up. I know there were also 100 other hands, but we're gonna, if you are okay with one more question?
Yeah,
okay.
Let him roll.
Thanks, Tim. That must have been pretty heavy, man. How did you navigate that, I suppose, when you, like, finding out stuff like that, when you're like, papers I've been part of have been used as evidence for this. Like, how did you guys navigate that in terms of your team?
It's very difficult, you know, and you've probably, Tasha, had a similar experience when you speak to the press, is that you can go in very naively thinking that, you know, these are good faith actors that are going to just report, you know, what I say as, you know, like, I mean, I gave an interview to the Daily Mail about a CBT study we did, and I thought I was very balanced and guarded, and then the Daily Mail headline was, "Doctor says throw your drugs away." I was like, where do they get that from? You know? And so you really, I think you have to engage. You know, I think if we don't engage like this, people are just going to take our stuff. You know, like, if we had not gotten involved in this, then Kondich would have had the last word on what our studies meant, and so we have to engage. But I think, as I learned also in this, I learned more from sort of my side of the arguments, discoloring our stuff than I learned, because I was like, okay, we're no longer in, we as scientists want, to make guarded conclusions that nobody could ever break. That's not the game they're in. This is adversarial dialogue, okay? So what happens is the one side makes the strongest possible claim and the other side makes the strongest possible claim, and they meet somehow in the middle. And you also, when you deal with the press, you have to be aware that they're not in the game of straight up reporting, honestly, if the public wanted science, they'd read our boring articles, right? So, really their job is to make it sound snazzy and exciting. And so, I think you do have to go in aware. And, it took us a little while to figure out that these, in a way, even our people on our side were not our friends. They were, they had an argument that they wanted to make. And so, yeah, it was heavy. Yeah.
All right, so on that note, let's take a break. We're going to cut it just a little short so we can let Felicity talk, start her talk on time. So 9 minutes, 10 minutes, a big round of applause. Also, I've been turned in a room key. Of course, they're unnumbered. So if you happen to realize you don't have your room key for the Dana, you're welcome to try this one.